Well, good morning, everybody. I'll go ahead and get started. I'm Shane. I'm the EMS coordinator for TriHealth. I'm with Bethesda Butler and McCall Hyde. Been with TriHealth almost 5 years now. Been in this role for about a little over a year now. Got to talk with Scott. Wanted to do a little bit of education on some seizures. And so I threw together a quick seizure PowerPoint for you. Morgan Township should have seen this one already. I put this together for them a while back when we did this one, but I've upped it and redid it a little bit as well. So go ahead and get going. You guys really can't see the PowerPoint here at all.
Be able to enlarge it.
What's that? It's a little bit better, I guess. So every presentation, you got to have some sort of an agenda. So we're going to go through all this. What is a seizure? Epidemiology, impacts, types of seizures, causes, triggers, what our assessment needs to be, how we manage interventions, some red flags for seizure patients that really we need to be keying in on, and whether we're going to be transporting or not. So starting out, what is a seizure? Abnormal, the textbook definition is abnormal, uncontrolled electrical impulses in the brain. Causes an overload in your brain, causes your body to do all sorts of different things. It can affect behavior, movement, sensation, awareness, but not all the time do we have that textbook seizure activity. We're going to really get into that portion as well. You guys know, like, postictal state. If somebody is postictal, what does that mean to you? Incoherent, confusion, altered mental status. Those are kind of the big keywords I would like to focus on as well. So seizures are really common, actually. 3.4 million people have epilepsy. EMS is often the first point of contact for people that are having a seizure for the first time. And 10% of the population will have seizures in their lifetime at some point, which I found kind of staggering when you really think about that. It's a lot of people. A lot of people have seizures. Early recognition of seizures, and especially those red flag things that we are going to talk about, can decide how these patients are going to turn out and how their care can go from when we get them to where they're at the hospital. So these are the ones that we're going to talk about. These are kind of the most common ones. So you got generalized seizures and focal seizures. What's the difference between those two? Generalized involves the whole brain. Focal, part of the brain, but can go to the whole brain. And we'll talk about that later as well. So you got tonic-clonic, that's your grand mal seizure. That's the one that we're all kind of, when you think seizure, at least for me, that's what I default to. That's that jerky, stiffness, seizure. Absent, atonic, myoclonic. Then we got simple partial and complex partial. Also could be simple focal or complex focal. Kind of depends on how you want to, which one you read, and we'll go into those. We'll start here. Generalized tonic-clonic, the grand mal. So they will start with that tonic phase, which is where they stiffen up, go unconscious, moving into the clonic phase, which is the rhythmic jerking of the seizure. These typically last like 1 to 3 minutes. They can go longer. They can be shorter. I've seen some that are 30 seconds, 10 seconds. I've seen some that are 5+ minutes. At that point, if they're the 5+ minutes, what are we starting to get concerned about? Brain damage, status epilepticus. Once we're hitting that point, it's like, oh, we probably need to do something. These patients are almost always postictal following it. They also can become hypoxic, okay? And that comes from when those prolonged seizures occur. You got to think they're not perfusing their brain, they're not breathing, therefore we're causing more damage. So that's your tonic-clonic seizure. Let's see if the video actually wants to play. Don't know if it will. Nope. we go. You see how he stiffened up a lot right there and then went into that rhythmic jerking. That is your most common, I feel, seizure that when somebody calls for a seizure, that's what they're going to be describing as they are seeing. And you notice what she did as well. Rolled him over on his side. Why do you think she rolled him over on her side? You can. I gotta switch all this up every time. That's gonna be fun. That's tonic-clonic. What are we gonna give for that? If we roll up on scene and you're seeing that happening, what's gonna be your first thing you're worrying about? You gonna put anything in their mouth?
Little bite stick.
That's old school. No. Airway obstruction. They swallow that down. Now you've just introduced a whole new airway obstruction. So we tend to avoid those. Avoid putting a bite block in or anything like that. Questions about tonic-clonic seizures. Like I said, those are probably our most common. We're going to get into the management of them at a later point. That's my favorite picture that I found. I love it.
You're still using the AI?
Yeah, I am. It's great. It creates some phenomenal imaging. So, absent seizure. And it's a really good picture because that is what an absent seizure looks like. These are a lot of times kids. Kids have absent seizures a lot and they go undiagnosed. They don't know that that's happening because they think they're just zoning out, staring off into space. You pretty much have to be on an EEG, I'm sorry, to catch these or be distinctly looking for an absent seizure. These do not last long. 15 seconds is usually the max these are lasting. The kid's not really going to be postictal afterwards, or the adult. Not saying that adults can't have absent seizures, but typically they are in kids. They may do like the eye fluttering, lip smacking, that type of behavior in these, not necessarily, but that's something that can happen in an absent seizure. Well, the big thing with absent seizures is that zoning out. That's the best way I can think to really keen you in. They just had an episode of, I don't know, 10 seconds. They weren't home. The lights were out. They weren't there. Glazed over. Kid's not going to remember. They're not going to be postictal. They're just going to move on about their day. Like nothing happened. So it's really, if you hear in those keys of, oh, that happened 3 or 4 times, this kid might be seizing over and over again in an absent seizure. Need to get them transported. Also, we did endocrinology here, what was that, last month?
Yep.
Blood sugars on all your seizure patients. Every single seizure patient gets blood sugar. Absent seizure, blood sugar as well, okay? Oh, we gotta go through this portion again. So you see how she quite literally just looks off into space. Not showing any really seizure activity. Hands twitching a little bit. Somebody describe that to you. What would you be thinking is happening to her? I know I don't instantly go to a seizure. Could be. Absolutely could be. But that's where that really good assessment comes in of getting a history on this person. Hearing, as soon as I would have heard like her hand was doing this, that flapping or something like that while she was zoned out, seizure. Go down that seizure route. That more than likely what has happened here. Myoclonics. I feel like these are probably the second most common. Yes. For those who can't see, or you might be able to see, Scott. Jerking, instant jerking. These are the dropsy ones is what I like to call them. They drop their fork or their coffee mug in their hands. They got the one hand's just shaking constantly. Okay. That is the myoclonic seizures. usually stay conscious during these. They usually are not unconscious, and they usually are going to be able to remember the event. Sometimes they won't. Kind of depends on. There's some other factors that could go into why they wouldn't. Age could just be a block out for it because it's moving into a different portion of the brain, maybe more of a different type of seizure. But for standardizing to a myoclonic seizure, they will typically remember what happened. Balance issues with these patients is very common. If a patient tells you, like, I do have a history of myoclonic seizures, they're going to have gait issues. What else is a gait issue going to kind of key into us? Possible strokes. So it's really getting that good history and understanding of where they're coming from on how we want to diagnose without diagnosing, because obviously we know we can't diagnose, but I also just mentioned they're not typically postictal. These ones, not postictal. When you're having those postictal patients, it's usually those tonic-clonic seizures. Okay, so if you have a patient who's experienced, they were drinking their morning coffee, jerky hand, drop their coffee, now they're okay, kind of start going down this. It might be a seizure still, but it's probably this one instead. You know what hospitals around you have neuro ICUs? Take a guess. Good Sam?
Price, you see,
Price, UC. You go Premier's.
patron.
Don't remember if they have a neuro. I don't think they do, but they might. I can't remember off the top of my head. But yeah, so all your larger hospitals are gonna have your neuro ICUs. First time seizure patients, obviously if they're seizure, take them to the closest hospital because they worry about ABCs. They have history of maybe consider the little bit longer of a transport to where they're going to get the definitive care. Just consideration. I'm never going to tell you.
B North.
B North has. They do not have neuro ICU. Good Sam's our neuro hospital for Tri-Health.
Jewish has one.
Jewish does. Jewish does. I'm pretty sure that's the only Mercy one that does. West does not, and Fairfield does not. Yep. So, just something to keep in the back of your head on these patients. Seizure patients are scary. I mean, they're one of my least favorites to have because they can go real south real quick, especially when their jaw gets locked up, and now they're not breathing. How are we going to get them some oxygen? You got to start thinking those things through, bagging them. You know, a lot of the times that's what you're going to have to do until they start coming out of that seizure or we get the meds on board. This is the one bad thing about having it on Teams.
Yeah.
So see, perfectly normal. Nothing, no seizure-like activity. But then those jerks. This is all from the Epilepsy Society. I thought these were some pretty solid videos. She doesn't look like a seizure patient. Do you think if you got called for that, you think she was having a seizure? Absolutely not. Absolutely not. This one I personally think is the most scary. This is the atonic. They just drop. Just drop. Notice very high risk for head injuries. Why do you think that is? They just go limp, down, unconscious. Okay. Loss of muscle tone is what big key factor of this. They're squawking and they drop. They probably will not remember. This is going to be your blackouts of time, if you will. There's no seizure-like activity with this usually, unless we move into a different type of seizure. That's something too of you may start with an atonic seizure, then you move into a tonic-clonic, or start with an absent move into tonic-clonic. Tonic-clonic's kind of your the one that when you think seizure, that one. I will say with these, they're typically not post-ictal. They will not remember the events of the fall. You're going to get called for a fall. But a key thing to hear is they just went completely limp. They literally look like they just melt when it happens. C collars on these patients. Probably would. They're not going to remember the fall, usually. I don't like dealing in absolutes in medicine. Usually they're not going to remember the fall. So they're probably by the time you get there, they're going to look perfectly normal. Hanging out, may have a scrape or something on them. Not going to know what happened. Not to say every fall that says they don't remember what happened is an atonic seizure. Probably not. But just one of those differential diagnoses, the one that you keep in the back of your head, the possibilities that might happen with these patients. I even have it in my notes right here. Cervical spine injury is common because they go limp. We're all headstrong, is what I always like to say. So when we fall, what hits first almost always is the head. Some of these switch to like the view of the person having the seizure. So this one is one of those, if I remember right. You see, just out. Gone. Literally like a light switch is the best way I can think to kind of key you in. And then it's right back on. Perfectly fine. Brushes themselves off and moves on about their day. You know, and it's kind of scary too when you think about that. How often does that happen on people with undiagnosed seizure issues? I would be willing to bet a lot. Or it gets brushed off as something else.
Does Jones have that policy? I think he does, but I think it's all controlled now by his medicine.
We'll get into medicines.
Yeah.
Because that is one of the biggest things with seizure patients is their medicines. So those are all your generalized, all the ones that affect the entire brain. Now we're going to talk about focal ones. So you could call this one simple partial, simple focal, same thing. They remain conscious when these occur. These are going to be your deja vu, like this has happened before. Your aura is common in these of, I feel like a seizure's coming on. It's probably what this is. It probably is the seizure, but we're not getting to the point of full tonic-clonic seizure or full whatever seizure disorder they have. No postictal typically in these unless they go into that next seizure, the tonic-clonic, advance into that. These twitching, have you ever heard of somebody's having a seizure when their eyes twitching? It happens. I've seen it at the hospital. Somebody came in because their eye won't stop twitching. Turns out they're having seizures. Something that simple. I don't know about you guys. My eye twitches a lot. It's usually because I'm dehydrated and don't drink near enough water, as all of us do. Tingling, vision disturbances, abnormal taste and smell. What's that sound like to you? What could that be? Somebody says like their left arm's tingling. Stroke. Exactly. And that's the thing about medicine is they go, a lot of our big hitter diagnoses could be mistaken for other diagnoses. So that's when it gets really good of getting history on these patients. Events leading up to for your seizure patients is huge. And then also knowing their medications as well. These do not last long, typically. These are very quick, very minor in the seizure world of my hand's really tingling today. Okay. You know, when was the last dose of your Capra? Oh, 3 weeks ago. Guess what we're probably doing? Getting ready to start into that seizure. This one is a viewpoint of the patient having it. They will complain of those visual disturbances. I feel like that's honestly one of the most common complaints for these are migraines. You've heard of the migraine aura, where the light, the photosensitivity with the light, same complaints here. And I like how it always says epilepsy is not what you think it is, because I know for me personally, if I think epilepsy, I think full-blown tonic-clonic seizure. They do that all the time. A lot of epileptics are these types of patients, these minor symptoms. Well, they do have the full-blown seizures. Yes, not discrediting that by any stretch of the matter. A lot of them are focal seizures. Sorry, I feel like I keep pausing because I have to reset that up. So complex partial or complex focal. These are going to have impaired awareness. These are the ones that might sound postictal as well. They have the confusion. They may the hand movements, the localized, because you got to remember one area of the brain that is seizing versus the whole brain seizing. So they're not going to have whole body involvement. It's going to be local involvement, whether it be a hand, a foot, an arm, lip smacking, whatever it may be, because it's that local involvement versus a general global involvement. So like I said, they will appear postictal. They also could be sitting right there in the chair having one. You have no idea. Then all of a sudden they're talking all crazy. They're confused. They don't know what's going on. They were fine 5 minutes ago. You get the call to that. Could be 50 different things going through your head. Seizure needs to be one of those that's on your radar as well. They also will have the aura. That is another thing with, I feel like most of the focal ones all have auras leading to, versus the generalized can kind of just hit. These ones are kind of your starting points for some of your major seizures. Not necessarily all the time, but something to remember on that is that's kind of where they start. Questions so far on that? Got some questions there? This is another viewpoint one. Those visual disturbances there. Because that's the area of her brain that is being affected by that seizure. 100%. I know that's what I would think. Somebody's complaining of visual disturbances right off the rip, their hands are numb or whatever. I'm gonna go down stroke first. And I believe it or not, a lot of our stroke alerts do end up being some sort of seizure disorder. That's one of our more common ones. There's nothing else on that other than they were talking and she's confused because she's postictal following that event. So this secondary generalized seizure, still technically a focal seizure because it starts as a focal seizure, but then it rolls into those full-blown tonic-clonic seizures. You could really label this as any of the focal ones. This is kind of your catch-all one for that. Starts local, goes generalized. Okay. Good history on these because there's going to be a pattern, a progressive pattern of the events. I had that aura. My vision started going bad. I have a minute and a half I do not remember at all. I've wet myself. Here we are. It's going to be your secondary generalized focal seizure. That is now full-blown tonic-clonic seizure. That's how it's going to be read as a diagnosis. For us, worrying about tonic-clonic, it's tonic-clonic seizure now at this point. Grand mal seizure, full body involvement. The whole brain has now been involved, so we need to be worried about our ABCs, about our glucose, maintaining good oxygen saturation on these patients, making sure don't restrain anybody seizing. I think that's common knowledge now because they will break something if they are seizing. I have seen it. Not a fun time. If they do go into that full tonic-clonic, they're going to be postictal. They're going to have that confusion, that altered mental status, and all that, because now we have went to full brain involvement, full blown seizure. Questions about our seizures? Those are all the major ones. You can get really, you want to go listen to a neurologist talk about seizures, they go.
Seizures and all that is a diagnosis.
So pseudo seizures is funny. So it is technically a seizure, but it's a stress-induced seizure or environmental seizure. Okay. Not to say that every pseudo seizure is faking. It's kind of a touchy subject when you really get to thinking about it. Treat them as if they were, but you're going to be able to see they're not going to be hypoxic. Their jerking is going to be more controlled, I think would be a good way to describe it. And you'll be able to probably pull them out of it without needing medical intervention. Big thing with them, make sure they're not hypoxic, always. Because to them, they are seizing a lot of the time. Okay. I didn't go into pseudo seizures here just because you ask 15 different neurologists about them, they're going to get 15 different answers. You ask 15 different docs about them, you're going to get 15 different answers. They're all treated a little bit differently. Go back to your basics, your ABCs, making sure we're doing that. They are perfusing still well. They're hypoxic, intervene. If it's prolonged, if we're like 5 minutes and they're still doing it, it might be a real seizure. I would say that's probably even way too long. I'll give them a minute, 2 minutes. They usually tire themselves out, but if they're truly seizing, they're not going to be tired out. It's going to continue. These are some of the most common ones. I'm not going to try to say the big words of them. I know them as Keppra, Lamictal, and Depakote. Okay. I'm not even going to try. The Keppra, I feel, is probably the most common because it works. It works really well. Big things with your seizure patients that are on any of these medications. Medication compliance. Knowing when their last dose was, if they've missed doses, anything like that, because if they are been par for the course, taking their meds as they should be, and they're still seizing, doc's going to want to know that, because now we're going to need to do a medication change or dose increase or something of that nature. Because it's not uncommon for somebody to be on Keppra for 15 years. All of a sudden they start seizing. They've been great, and all of a sudden now it's not working for them anymore. Need to do that. They've become resilient to it. Need to switch. So one of my first questions, when did you take your medicine last? Whichever it may be. Make sure we know that. Hospital will love you when you tell them that. Lamictal is kind of your more, you'll see that one on your long-term patients as well. Keppra and Lamictal both are going to be your real long-term. Depakote, they still use it. It's just not as prevalent anymore. Don't really know why. The other ones, probably because the other ones work a little bit better. So just I was willing to bet Keppra and Lamictal are going to be your top two. You're going to see. Nothing really concerning for us in the field when it comes to these, other than, are you taking your medication? If you're not, why aren't you? When was your last dose? Have we changed your doses recently? Because that initial, when we're trying to find your right long-term medication, is excuse my language for any women that are here, is a bitch and a half of finding the right therapeutic dose for those patients. They will seize, and they will seize often still, because we're not at that therapeutic threshold that we need to be with these medications. They get frequent labs drawn on them. Yeah, even medication compliance. That is the biggest thing with medications for seizure patients. I cannot stress that enough. Rescue meds. We know one of these very well. Good old Versed. That's what we have in our drug boxes. That is what we use for seizure patients. Some common ones at home is the Valium. Valium is able to be given rectally in the suppository. Kids will have that one a lot. Question I want you to get if you're getting dispatched for a seizure, did you have to deploy rescue meds? Because pretty much every seizure patient has a rescue med of some sort. If they say, yes, I gave Valium 2 minutes ago and they are still seizing, you're good to get Versed still. Do it. Get them out of it. The worst thing you're going to do is you're going to need to support their airway. So be prepared for that because we're giving a benzo. That's a common effect from a benzo. Ativan is typically, we use that in the hospital mostly. That's one of ours go-tos. We get Versed too sometimes, but I feel like all the docs like Ativan for whatever reason. So I threw the Ativan on there just for that reason. We did used to have Ativan out here in the field a while ago. It might come back. It might not. I don't foresee it really coming back. I see Versed works very well for the field. I think it will stay, and that will be our rescue med there. Early administration. When you have a seizing patient, say they've been seizing they seized with you. How long are you going to let them seize before you give those meds? Versed. I like that answer the best. How are you going to give it? How can you give it? IV is the best. Obviously, if they're seizing, are we going to be able to get an IV on somebody who's a tonic-clonic seizure and stiffer than a board and jerking all over the place? Probably not. Give them a shot. Shoot up the nose. I personally go for the nose just because it works a little bit quicker. So, early administration of your rescue. That's what I want you to get from that. What causes seizures? I have a whole list there of things that can cause them. Epilepsy, trauma, strokes, low blood sugar. Kind of linking that back into our endocrinology lecture. Low blood sugar causes a lot of issues that it's a very simple thing to rule out and real simple thing to fix. Flashing lights, that grows into your epilepsy. It does. So I know at St. Clair, we have a kid who does have epilepsy. We go on occasionally, get called for a seizure. You're going to be running hot. Turn off the lights when you're coming on their street. One less thing. One less environmental aspect to provoke the seizure. Electrolyte imbalances. Obviously, we don't have a lab out here in the field, but that's something that if they just had labs drawn, they bring them to the hospital with you. Or were any of them off? Oh yeah, their magnesium was 15. Oh, okay. Cool, I'll let the hospital know that. Because so we kind of know where we're going from there. A lovely assessment, because we don't know that we have to make sure the scene's safe first. Duration and description of seizure activity. If a patient starts seizing and you are the witness, time it. Every single time. Time them. You have life pack 15s to 35s. So they have its clock on them. Watch that. You should have a clock in the back of the medic unit as well. As secondhand, cool. If not, you got to watch on you. Time them. Time them. Okay. Because the hospital, that's one of the things that they're going to ask when they have a seizure. How long did it last? What were they doing when it happened? What were they doing leading up to the seizure? Because then if they were having that aura, they were having those visual disturbances. Okay, we went from a simple to a full tonic-clonic, so now we're in that generalized, and we're having a grand mal seizure. So we've had that really good picture, that timetable, if you will, of the events leading up to why we are here now. And that can just help in the long term of these patients' outcomes and overall care. Level of conscious post-seizure. Why is that important? How quickly they come back, and it can help us decide what type of seizure they were having, if they were even having one. Okay. And then I had to throw in check glucose there as well, because one of my things, I'm on the team of a blood sugar should be a normal vital sign for every patient. It's a very simple, it's cheap. Check blood sugar, it can tell you a lot of things. And then the history. I've said it 15 times, I'll probably say it 15 more before this is over. Good history, good medication list, when they last took their seizure meds. If they're not on seizure med, this is the first time seizure. Uh-oh, we got some issues. There could be blood in the brain. There could be God knows what, infection, tumor, who knows. Trauma. Trauma causes seizures. Say right now, with a little foreshadowing, we have some cases here at the end. If it is a traumatic event and then they start seizing, not a good time. It's not good. It's not good. Lots happened in that brain. That brain is very damaged and you need to go. You need to move. Okay. We know how to manage patients. It's just one of those checkboxes things when you do EMS education that you have to put on is EMS management. Okay. Big thing, do not restrain seizing patients. Pad your cot for them so they don't whack their head on the rail or whatever. When I say restraints, seatbelts, they're okay. We're moving down, you got to have them buckled in. I'm saying don't hold their arms down. If they do start pulling up and they're pulling on that seat, unbuckle it. Because they will break their boots. They will. I've seen it. Dislocated their shoulders out. It's kind of crazy. Because you have to think about it. When I did this at Morgan, one of the guys said, so it's essentially like VFib of the brain. I was like, that's actually a really good way to think about a seizure. That's what's happening. We know what VFib is on the monitor. We don't have the monitor capabilities out in the field to look at the brain waves. That's essentially what's going on in that brain. There are just electrical impulses going crazy if it's a full-blown tonic-clonic seizure. So you think about that, all those muscles are going to do whatever they want, however they want. You put resistance to that, you'll stop a bone like that. Keeping the airway clear. We mentioned a bite block earlier. Back in, when I first started, they said, yeah, you're okay to put something in there. But they realized now we're introducing an object into their airway that could possibly become an obstruction. Last thing we need is somebody to be seizing. Now we have an airway obstruction. How are you going to get that airway secured now? Cracking them. That's your only option. Okay, so keep your airway open. There's a lot of secretions when it comes to seizing patients. I feel like they drool or they bite their tongue, and now there's blood in the airway. So have suction ready. Be prepared to suction them once they're done. Again, I have glucose on there because glucose is my friend, and I always mention glucose. And don't be scared to give them oxygen because if they're seizing, they're going to be hypoxic because they're not doing the gas exchange. They're not fully breathing correctly. There's some oxygen on them. Even if the monitor's saying they're 99%, give them a little bit of oxygen. It's going to be okay. It'll be okay. And then benzos. We talked about our rescue meds. Early deployment of your rescue meds is what you need on your seizing patients. Your red flags. These are the ones, if you hear these phrases, I want you to instantly be on high alert. It's lasted over 5 minutes. You get on scene, they've been seizing for the last 8 minutes. Fit and get them moving. You need to get some meds on board too, and be prepared to take that airway too. Okay. Multiple seizures without regaining consciousness. What's that mean to you? Could be. So what that means to me, you seize for 30 seconds. Now you're post-ictal. You go right back into a seizure. 30 seconds later, you're back out. You go right back into it. It's that repeated over and over and over. You're not seizing the whole time, so you're not in that status epilepticus, but you're on the verge of that status epilepticus. There's a lot of docs that will call that still status epilepticus if you're not doing that recovery. But like I said, one of those depends on what you read. They're not regaining consciousness at all. They're not going back to any sort of baseline. They're just seizing and seizing and seizing. And then persistent altered mental status following a seizure. What's your shortest transport's what, to Fort from here? 10 minutes, 15 minutes? You got called, we'll go to the far side, by Morgan. You get called out there for a seizing patient. They seize for 2 minutes. You took 7 minutes to get there. They were out of the seizure when they called. They finished the seizure. So we're at 9 minutes, okay? By the time you get to Fort, they are still completely out of it. Is that normal or no? So we're at like 30 minutes post-seizure. When I say completely out of it, completely out of it. Not has it, mental status hasn't regained at all. they should start coming some sort of around, maybe opening their eyes a little bit, maybe, not trying to fight you. I don't know why postictal people like to try to fight. One of their favorite things to do. Things like that. So having that persistent altered mental status in a postictal state, there could be injury to the brain. Okay. There could be a bleed. Those are things to keep in back of your head to remember for that. Some more. First time. Never had a seizure before. Why are we seizing now? What has happened? What has happened to cause a seizure? Okay. Trauma. That's pretty self-explanatory. We don't want trauma. They fall, they seize, now their head's busted open. It's trauma. Also, they fall, they seize, they have a head injury of that sort, put a C-collar on them. I always do a C-collar and a blood sugar plug any chance I get. Two very simple things that we, in the field, I feel we need to get a little bit better and more proactive about doing. Pregnancy. For those who don't know, my wife is pregnant currently. I have a little baby girl, real excited about it. She starts seizing now. God forbid that ever happen. Eclampsia. A lot of bad things happen when pregnant females start seizing. A lot of bad things, not only to mom, but the baby. What's our med for pregnancy seizing females? It's kind of a trick question. Mag. You can do mag. You can do Versat too. Versat's okay. Mag. Mag is your correct answer. What do you carry? What is on your stroke box here? How much mag do you got? You got 2 grams or 4 grams?
4.
You got 4? Hang the bag. Let it go. It'll be okay. And then uncontrolled airway and breathing. Of course, we all know that. I think they teach you that day one of EMT school. If the airway is not secured, get them to the closest facility. I don't care if it's just a 2-bed ER. Get them there. Okay, I don't think there's any 2 beds ER, but you know what I mean. Transport considerations. Transport every first-time seizure. If they have never had a seizure before, you take them to the hospital. Status epilepticus or those prolonged seizures like we were talking about, those need to go. Okay. Consider trauma center. Your closest trauma center is what?
Westchester.
Westchester is probably, yeah, I was trying to think if it was Westchester. So that's what, 30 minutes?
Go downtown, go extra 5, 8 minutes.
Don't disagree with you there.
It's all highway.
It's all highway. I do not disagree with that decision. Or flying. It's another option out here. I mean, you got a beautiful helipad right there on your back step. Don't be scared to fly a traumatic seizure patient because they more likely have a head injury of some sort. You need to get them. You need to get them somewhere quick. Continuous monitoring around. We know that. And notification. When you're calling for a seizure patient, they're going to ask, "Did you witness a seizure? Yes or no?" You'd say yes. How long? What were they doing? Those are going to be, at least they should be, succession of how those questions are asked. Okay. Then probably going to fall in, did you do any interventions? So have you given any Versed? Is essentially what that's asking. ETA when you're here, or do they have a history of seizures? Because all those things, when you're notifying a hospital, it's starting the process for that nursing staff. May not sound like it a lot of the time, but it is. They start thinking about resources that they're going to need for that squad coming in. Bethesda Butler, we have room 14, which is our big room. We have a new onset seizure that's coming in. They're probably going to go in 14. We know we need that room open. Fort has 4 and 5. They're going to know those rooms need open for that. They're full. Okay, now where can we put them? Figure it out. Maybe move somebody out of a room. Maybe get a doc on the phone. Things like that. Just all things to think about. Questions before we move into case studies? Anybody online have questions?
Click the chat.
I can see it
Oh, okay.
right there. I can only see like 2 lines. I don't think there is, so we'll move on to a case study. All right. You're dispatched, single vehicle, single motorcycle into a ditch. 44-year-old male standing on the edge of the road. He's agitated. His helmet is on. Helmet has multiple cracks and a broken visor. States somebody forced him off the road, and he doesn't want you to be there. He doesn't want to talk to you. You can eventually convince him to move him back to the medic unit. Where are we thinking? What are we thinking off the rip on this guy? Trauma. Why?
All the obvious.
There's a one phrase in there that would instantly go to trauma with a head injury. Multiple cracks in the helmet with a broken visor. He has hit his head. Helmets are great. That would probably save his life. Because think about if he didn't have a helmet on. That's a skull then that's broken. So for anybody who rides motorcycles, always wear your helmet. Please, for the love of God, your local ER nurse. But yeah, trauma. That's instantly where I go. He's got a head injury. He's agitated with clearly some sort of head injury. He's alert and oriented times 2. He has an obvious injury to the right arm. He becomes increasingly agitated. So we're progressing. We're progressing. Okay? But then suddenly becomes quiet. Stiffens on the stretcher. What do we think's happening now? We thinking there's some swelling in that brain or some fluid going around that brain that shouldn't be there. I would agree with you completely. Stiffens on a stretcher. What type of seizure are we thinking we're heading into? Which one of those was the stiffening one? On it? Because we're going into that tonic-clonic seizure. That's stiffen to unconscious because unresponsive in the next line. Breathing, grunting, and pulses are present. So what are we thinking now? What is our number one priority when this all happens?
Seizure, I can control it.
Okay. How are you gonna do it? What kind? Perfect. How you gonna get that airway now that he's stiff and not responding any longer? Bagging him. Love it. Love it. 30 seconds. That seizure lasted. Okay. You got all the good stuff. I put C-spine in there. Bless you. We hadn't mentioned C-spine.
C-spine.
You need a rag or something for the back of your head? Like that was rough. C-spine. I'm gonna say C-spine all the time. Get the C collar on him. You're gonna fly this guy? You're gonna ground him. Day like today. Pretty nice out there, isn't it?
Depends on where air cares come from.
That is such a true statement. They're at Butler County right now.
Yeah, maybe. I'm just ground. Mid-morning traffic, bad go to UC. You're good.
No, I would agree with you though. He needs to go downtown.
Yeah.
He needs to go downtown. He needs a trauma center.
Throw him some meds if he comes out.
Probably won't. With a seizure after a traumatic incident like that, he's probably got a lot of issues happening up in that brain. Especially with him being agitated prior to, with all that damage. I kind of threw that. Yeah, he has a broken right arm. Who cares about that at that point? You know, it doesn't matter. Questions on that one? That's a pretty straightforward, easy. This is what's happening. 3-year-old, sick. Everybody already knows where this one's heading. Mom states kid's been sick for 2 days, runny nose, cough, and a fever. Okay. What are you going to be concerned about on a temp on a kid? How high is it? How high when you're like, oh shit.
Everybody's different.
Everybody's a little different. You're not wrong. I usually say 103 to 104. That's kind of my range. But if we're above 103, I'm like, ooh.
Last time they did Motrin or Tylenol.
Love that question. Kid's lethargic, not looking at EMS, rapid breathing, hot to the touch. There's supposed to be that bottom part wasn't supposed to be coming up right away. It was supposed to be a click and go forward, but clearly it's not working. So, you're getting more information from mom. Whole body jerking. And grunting. What do we think's happening now?
Whole body mechanism control the temperature.
How are you going to control temperature in the squad?
Clothing.
What else we got back there? We got air conditioning. What else?
Cold packs.
Cold packs. You guys got cold fluids or no?
Both.
Gonna put a line in the 3-year-old and start some cold fluids if their temp's 105. Go for it. The hospital's not gonna get, but don't wide open a liter bag. Give them some cold fluids.
Cold, I mean, we got the heated and then just a normal
Oh,
temperature.
104 is the temp on this one. So, time seizure activity. Okay. That is so important. I cannot stress enough how important that part is of knowing how long that seizure lasted. I know parents, bystanders, they're not going to be as good about that time as we can be. So if it happens in the back of the truck or while we're there, make sure we're getting a good time on those seizures. Okay. I have a question mark next to IV. The 3-year-old who's good at sticking kids. There's not many medics that are going to be like, I'll stick the kid. It's just not. One of those things that this is one that we probably should get an IV on, or at least try. At least try. How are you going to give your Versed? You got rectal Versed in the squad? You don't have rectal Versed in the squad. Mom might have rectal Valium. Maybe. If she has a seizure history. Nose. I think kids do better in the nose. You can give it IM. Transporting. How are we going to transport a febrile seizing kid? We got to ground them, fly them.
Children's delivery for us.
Ooh, they're going to love you. Children's delivery is so much fun. I digress on that though.
Or down.
That's kind of the beautiful thing about where Ross is located. Downtown's really not overly far. Probably an extra 30, maybe an extra 5 to 10 minutes to out to Liberty area for those hospitals, depending on time of day, obviously. So I would that would be something I would keep in the back of your head. Do I think this kid needs to go downtown? Granted, you take them to Liberty, they're probably going to strip them downtown. But are you wrong to go to Liberty? Absolutely not. Are you wrong to go to any hospital around you with an actively seizing child? Any hospital can handle that. Any hospital. That is one of my things. We are in an ER. We can handle whatever you bring through the door. We may not keep them there. We may ship them out, but we can get them stabilized. And one thing that an ER has that we don't have out here in the field is a physician. Always remember that. I will always defend any crew that brings anything into any of my hospitals. As long as you give me something to chew on in the narrative. Don't give me the 2-sentence narrative with nothing there because I can't do much then. Had it happen too many times. For this patient though, if they are actively seizing and you've given meds and they are still seizing, you get them to the hospital. I don't care which one it is. You get them to it because that doc needs to get something going sooner than later. Recognize your seizures, what types they are, what they can be, what they can lead to. Like I said, those simple focals can lead into full-blown tonic-clonics. Once we're at the tonic-clonic, we're not really leading into much other than hypoxia and brain death if we don't intervene quickly. Scene safety and ABCs, we know that. We know the red flags, okay? Prolonged seizure activity, along with status epilepticus, along with not coming out of seizures, okay? Those are things that we need to, if we hear those, we need to high suspicion of something happening. Don't be scared to give the meds. Don't be scared to give Versed. Give it. They're seizing. Give it. Okay. I know a lot of people are like, oh, it was only a 15-second seizure. Give Versed. Because they're probably going to do it again. They might not, but they could. Might as well be proactive. And then transport. I live on the side of caution transporting all my seizures. Unless it's like a known who the rescue meds have worked. This happens 3 times a day. Somebody just freaked out and called you this time. Maybe not that one. Most of the, and that goes back to one thing I've said multiple times, getting a good history on the patient, of understanding where we're at, what we're coming from, and all that. Questions, comments, concerns? Who's at Morgan right now?
Nobody that's had it right.
Okay, cool, perfect. So I don't think any of them have questions. Who else was on here? I don't remember who else was on.
Phil Clayton.
Phil's got any questions?